Hello, I am Dr. Ahilasamy from Chennai. I am going to show a case of bilateral extensive Sino Nasal Polyposisis, a recurrent case, and deviated septum to the right side. Already a septoplasty done, not properly collected. I am going to show the CT images, that's a coronal CT scan images showing opacity on all the 8 sinuses along with the nasal cavity. Polyps in the nasal cavity, in the sinuses, everybody. But the soft tissue scan showing no heterogeneity, that way there is no fungal or that is AFRS. I am going to take this case under local anesthesia. This case being done for around 1 hour and 10 minutes. I have slightly edited to around 22 minutes. This is a diagnostic endoscopy. On the left side, some secretions, polyps. They have chopped the middle turbinate partially and they have done some MMA secretion. This patient has been treated with lot of polyps up to vestibule in the OPD examination, but I have treated the patient with oral steroids for 1 week. Left side it has shrunk a lot, right side moderately it has shrunk. You can see polyp up to the floor. The first step to pack the nasal cavity with the roller gauze soaked in 4% lignocaine and adrenaline in the ratio of 1:1. That is, I used 10 ml of adrenaline and 10 ml of 4% lignocaine. After decongestion, this is a thing they have done in MMA. It's a stump of the middle turbinate which has been partially resected. Polyps everywhere. There were a lot of polyps with 1 week of oral steroids. Lot of polyps have shrunk. Now I am giving the spinopalatin block on the left side where the middle turbinate will be curving and attaching the lateral wall just above the inferior turbinate. Please watch these videos on big screen or pair your mobile to the big screen TV screens to have a good clarity. Do not watch in just mobile. You will not appreciate the clarity. You can see the good blanching. Now I am giving the anti-ethmoidal nerve block at the root of the middle turbinate or axilla of the middle turbinate. You can appreciate again the good blanching. So on the right side you have hardly any space. I have already packed the right side also. Now I am going for the greater palatin block or the transoral spinopalatin block. Palpating the foramen, which is the only foramen which is 5 to 6 millimeters, and it to the posterior bony edge of the hot palate, midway between the gingival margin and the midline. This is the only area the needle will go. See, the needle which I have bent for around 2 centimeters has gone fully. Aspirate and give. If blood is coming, you are in a vessel. If air is coming, you are in the nasopharynx. Give around 1.5 to 2 ml of ropivacaine. That I use is 0.5% ropivacaine with adrenaline. I take 20 ml of ropivacaine and I add 15 drops of adrenaline for the infiltration. With only this block and the anti-ethmoidal nerve block on the right side, this anti-ethmoidal nerve block on the right side, I did the whole FESS on the right side. I will be showing. Now I am starting the FESS functional endoscopy surgery on the left side. First step to shave off the polyps and to get a clear anatomy. Already the middle turbinate has been resected. I don't know the condition of the middle turbinate prior to the surgery. They don't have the prior CT scan. There's a thick synechiae between the middle turbinate stump and the uncinate superiorly, which is not properly removed. See, appreciate the field quality under local anesthesia. Hardly any bleeding. That's the beauty of doing under local anesthesia with the proper IV sedation. Here I have given fentanyl 50 micrograms as well as dexmedetomidine infusion as in this syringe pump. Of course, I will keep anesthetics with me. Shave off all the polyps. I am using a Somat Vetronic debrider. You can use a Indian or a Chinese. The results are same if you use the same blades, and you should have a good suction. Appreciate the field quality under local anesthesia. You need not put suction now and then. You need not give saline washes and everything. Debride all the polyps to get the available anatomy after a revision surgery. These patients tolerate very well under local anesthesia. This is a 48-year-old male patient. The previous surgery had been done under general anesthesia. Now I am doing under local anesthesia. Patient wanted under local anesthesia. Very well tolerating. This is a polyp in the superior meatus or the sphenoethmoidal recess. Remnant polypoidal middle terminal has been shaved off. Now the synechiae between the middle terminate and the uncinate superior part left begin is cut through with a true biting forceps, upturned true biting forceps. Kept a pack, now and then keep a pack to decongest the areas. Now I am using the Nagashima's backbiting forceps to do a good MMA. Already a small MMA is persisting. So I am using a Nagashima's to take out the and or the widen the MMA and debride the soft tissues around the middle meatal and rostomy to make it a very wide opening. So that post-operatively the steroid sprays or the irrigations will go into all the sinuses very well. So what are the left behind tissues in the anti-ethmoids is being taken off, and the left behind superior part of the uncinate is being also shaved off. Again, appreciate the field quality. When you have a very good field quality under local anesthesia, you will hardly end up in complications. Now I am removing the bulla, which has been left behind in the previous surgery. The previous surgery had been done 4 years back. The note shows FESS with septoplasty. That's all. Bones are very thick because of neo-osteogenesis, because of the previous surgery. So I have to use the cold sore instruments to take out the hard bones of the anti-ethmoids. There's a polyp and everything from the front is being cleaned. Again, I am using this shaver. It's a quite lengthy video, around 22 minutes, but it will be very helpful for the youngsters and beginners and people who come into functional endoscopy surgery to learn. It will be very helpful. Again, I mentioned appreciate the field quality, and you can run through and work so fast in the ethmoid, skull base and everything. Again, the posterior lip of the MMA being taken care of with the true biting forceps. That's the lamina. All the shells have been removed from the anti-ethmoids. That's palpating the frontal. It's a small frontal, not small, moderate frontal on the left side as well right side, which has been opacified because of the scarring and everything at the right. I have opened the frontal. Now I am working with the 70-degree telescope. Previously, so far, I was working with the 0-degree telescope. For most of the FESS, I work with a 0-degree and 70-degree telescope. For nasal surgeries alone, I use only 0-degree. Previously, I used to work with 30-degree, 45-degree, etc. I no more use 30 and 45. I routinely use 0-degree and 70-degree. Of course, I use 90-degree to inspect the lateral wall and anterior wall of the maxillary sinus sometimes. The frontal has been very well opened. There is no much only scarring. All the discs has been removed. Still depreding the frontal recess area or the polypoidal tissues. And now I am working in the ethmoids, going for the sphenoid sinus. You can see the superior turbinate coming into the view. So going medially to open the sphenoid sinus. In this case, the left sphenoid sinus was very small, hypoplastic. Still I opened, there was hardly some secretions. There's a left sphenoid opened. The remnant posterior part of the middle terminus is being taken care. More work is done in the ethmoids to have a good, smooth and clean cavity. Maxillary sinus is having a wide opening, so I am packing that area with the same 4% lignocane and adrenaline, giving infiltration for the septal elevation. I am doing a revision first. Now I am using my own design, Dr. Ahila's dithyramine knife, to make the incision for the septoplasty. This case, the septoplasty is a very tough one because of lot of fibrosis. They have left behind the deviated bone, which I removed. Being a highly edited video, I'll be skipping lot of steps of the septoplasty in this case. See, lot of fibrotic tissues, scarring and everything. Now the deviated bone that has been left behind will be removed. That bone will be removed. So we have got lot of working space on the right side. Now I am showing off the polyps on the right nasal cavity to again to get a good normal anatomy of a already operated nasal cavity. Gently taking out all the polyps. Please watch these videos on big screens or laptops, or pair your mobile to your TVs, that is your smart TVs, where you can pair your mobiles and watch it. Then you can appreciate the quality very well rather than watching just only in the mobile. Lot of polyps. I am doing this surgery on the right side with the anti-ethmoidal block and the greater palatine block only, because I couldn't give the spinal palatine block on the right side because of the extensive polyposis. The polypodal middle terminate on the right side is also being shaven off. We I operate all these patients in the morning, admit the patients previous night, and evening I discharge the patients as daycare patients. We don't pack the nasal cavity after any nasal surgery like septoplasty or rhinolith or any nasal mask or after any sinus surgeries. All the patients will be discharged on the same day. Of course, we tell them to keep cotton plugs in the nasal vestibule while they are sitting or standing, because for first 1 or 2 days there may be small drops of blood dripping. While sleeping or lying, we don't advise them to keep cotton plugs in the nasal vestibule. Again, appreciate the field quality, very minimal or hardly any bleeding. And whatever the blood that goes into the vagina should be sucked immediately and cleared, or ask the patient to swallow. Otherwise, they may aspirate and they may cough and disturb your surgery. Now again I am using on the right side the Dr. Ahilasamy dissector to dissect the unsnake. The unsnake had been polypodal. Now I am entering into the maxillary sinus. This is maxillary sinus. Since it's polypodal, I couldn't show it very clearly, but I will debride the dissected tissues and you can have a glimpse or a good look of the middle meatal antrostomy, which has been done with the Dr. Ahilasamy dissector. Again, debriding. Without debrider, you cannot do a good job in these kind of polyposis cases. Always invest in good instruments. Use debrider in all the sinus surgeries. Lot of polyps filling the maxillary sinus, which I am debriding. And widening the middle meatal antrostomy with the shaver itself. Patient is very comfortable under a local anesthesia with a moderate IV sedation with fentanyl and dexmedetomidine. All the polyps are being taken out. Patient cooperated very well for 1 hour and 10 minutes. Evening, since there is not much bleeding, we don't pack the nasal cavity and we discharge the patient the same day evening as day care. All the polyps from the maxillary sinus being debrided off. The bulla which is intact will be taken out. So, with the Blackessley forceps, I am taking the bulla out because the bones are very hard because of the neoosteogenesis of the previous surgery. Do not destabilize the middle terminal. You can see the middle terminal is still rock solid and still in a medial position sticking to the middle septum. Most of the bulla will be taken out with the that's a spinal sinus. I have edited the video. Now I am going to the frontal on the right side. Lot of polyps in the frontal recess is taken out. This is working with a 70-degree telescope. Now my curved sucker is in the frontal, taking out more polypodal tissue from the right frontal recess. Still some polypodal, of course you can see the frontal sinus also, but I will shave it off the polypodal disease in the frontal recess. With a rad 60 blade, I am taking out the polypodal tissues around the frontal recess. So the frontal sinus is well open, got a good view. Now I have come to the 0-degree telescope. The left side which has been operated is very good, clear, and no bleeding and everything. Smooth cavities, septum okay. On the right side also fairly good cavity. We start nasal dose from the second post-operative days with saline or with bicarbonate. Small molecules should be removed. Don't leave it. That may promote granulation. Patient is very comfortable, hardly any bleeding. Thank you for watching. See you in another beautiful video. Contact me anytime at the above address or WhatsApp me. Thank you.